Welcome everybody to Nene CCG's second annual general meeting. My name's Darren Seeger. I'm a local GP in Moulton Surgery, and I have the honour of being the GP chair of Nene. Today is a first for us because we actually have some members of the public who are hard of hearing. So we have deaf interpreters. And I've not actually worked with deaf interpreters at a public meeting before, so they're going to tell me they're going to tell all of us if we're going too fast or too slow. Just a few housekeeping rules at the beginning. There's no fire alarms planned, so if the fire alarm does go off, there's 3 exits you can use, and there's an exit at the back or just straight as you came in. We're going to try and keep this to time and finish by 7 o'clock. So we're going to try and run through the presentations to give plenty of time for questions and answers that I'm sure there'll be many, and we've had 1 or 2 written down already. So without further ado, I'm going to start. So just to, for those who didn't come last year, just to explain Nene CCG. So we're made up of 8 geographical localities across Northamptonshire. So the only areas that we don't cover are basically Corby and Oundle and Wansford, who actually go to other groupings. So that's our practices work within those geographical localities. So to try and identify what the specific patient population needs are for that local community and to address them. So the whole point of the changes in the NHS were for local clinicians to work with their local populations to deliver better healthcare services. But the 8 geographical localities in Northamptonshire have come under one umbrella, which is NHS Nene Clinical Commissioning Group. We have, we're just explain, we're the 6th largest in the country. We cover 640,000 patients, and we have roughly 400 GPs working across 69 practices. The vision of our clinical commissioning group is very simple. It's to help people lead the best possible life from beginning to end. So really from the cradle to the grave. The way we're going to do that is improve the quality, outcomes, and clinical standards for all patients. So that's what we work tirelessly to do. And the values as an organization, as a system leader across health, is really to be effective, compassionate, supportive, and most importantly, to make sure that all patients are safe. Our priorities are tied in with the Health and Wellbeing Board's priorities. So for those of you who may not know, the Health and Wellbeing Board is now a statutory new board that works across the NHS and social care, but also involves the districts and boroughs and the voluntary sector, patient groups, and the key strategic priorities for both of us are to improve children's welfare, to empower and enable local people to take greater control over their health and well-being, to make sure that they have a healthier lifestyle, because we know that we can't continue doing the same things that we've been doing for the last 50 years. We have to move into prevention and try and help people stay well. And there's a number of our colleagues in the audience that are working tirelessly to do that. We've got a strategy for vulnerable adults, so making sure that the frail and elderly in our society are safeguarded and have access to the right services of care that may not always be going to hospital. And the last point is really emphasizes that, to support the elderly and keep them well and independent. So just want to run through a number of our successes, and I will then allow my executive director colleagues to then take us through step by step each of these areas. But we've set up a cardiology clinical network, so working across both Northampton and Kettering hospitals to deliver better services for all of the patients. We've strengthened our clinical leadership, so we've made sure that actually we have GPs focused on the statutory responsibilities of the organisation around the NHS constitution, and that's and also we have a number of GPs who are also supporting practices and working with them to develop commissioning plans. So we've been through that process this year. We've continued to work to improve access to primary care. We know nationally that's a great problem, and locally it is as well. We were the Health Service Journal Awards finalists for improving partnerships between health and local government. So that's a key bit of our work, is to work in partnership with all other commissioners of health and social care. And we've also, it's very important to educate the public, and we've done a number of campaigns to help the elderly access the right services. We haven't championed this enough, but we actually sent a member of our own staff, David Anderson, who has a lot of experience in emergency and acute care, out to Sierra Leone to support the Ebola crisis. And he's brought back a lot of that learning, and we're very proud of the work that he's done, and we've supported him to do that. We've got Dr. Yasser Javed is a GP with a special interest in cardiology, and he was nominated as one of the GPs of the year for the entire country. He reached the final for that. We have a particular issue in the county around children's safeguarding, and the Care Quality Commission did an inspection and found that our standards of child protection referral from GPs is one of the best they've ever seen. But that's not to, but it's very important to state that there's a huge amount of work that still needs to be done to ensure every child is safe. We have new wheelchair service and weight management pathways to make sure we support those groups that need that. We're committed to supporting our military veterans' physical and mental health, and we have members of our team who were out there. There's a stall there, but that's a huge issue to support our members of our public who do an obviously extremely difficult job and often come back with post-traumatic stress disorders that can come out years later. So we've worked with our member practices to make sure that those patients are identified and given the support they need. And we've recently undergone a change of chief executive accountable officer. So Ben Gowland left earlier in the year. Stuart Rees, who will be doing a presentation, has done a fantastic job in stepping our organization up a lot, and John will start in October. Part of the way we work is obviously we need to hear what the public and citizens and patients and carers and service users would like from us. So we've undergone a series of events over the summer, and there's still many planned. So if anybody wants to access those, the details are available on our website. If you just type in NEN CCG into any search engine, we come up. So that's a quick canter through the introduction. I'm going to now hand you over to James Murray, who's our interim Chief Finance Officer, who's going to take us through the finances.
Right, you'll be pleased. We're working. Be pleased now, I'll keep this short and sweet. So I'll give you a sort of feel for where we performed in 14-15 and the outlook in 15-16. Just to sort of set a bit of context, the allocation we get as a CCG, we act as a commissioner. So we effectively set the envelope, financial envelope, for what can be spent on healthcare within Northamptonshire, and it's our responsibility to sort of distribute that allocation through the county and also out of the county for certain services we buy from Oxfordshire and one or two other places. We have some key financial targets to deliver in 14-15. First of all, we received about £689 million. and we had to make sure that we achieved a small surplus on that of £500,000, which we achieved. We also have what we call a revenue administration spend, which is really what we call a management cost envelope. So we're only allowed to spend so much money on defined management. For us, that's set at 15 million, and we underspent on that by £1 million. We also have, for our providers, we have to make sure that we pay them on time. So again, we set a target of paying all our invoices of 95% within 30 days, and we achieved that quite comfortably. And also we have to manage within our cash balance as well, so we managed that quite comfortably. So overall, in terms of our financial duties for 14-15, we hit the targets that we were required to do. In terms of that 689 million, that sort of pie chart just gives you an idea of where that allocation goes. So the biggest proportion of that goes into the acute sector. So in the main, that's Northampton General and Kettering. And then there's also, as you can see there, big chunks in terms of primary care and prescribing. What that doesn't include is the actual cost of the GP practices themselves. So that's purely some add-on services that's still commissioned by NHS England at this stage. And then going down, you can see we spend money on mental health, community services, continuing healthcare, etc. The other thing we don't commission at this stage is specialised services. So there are a number of sort of highly specialised, low volume services, which at this stage are still commissioned by NHS England as well. So that will include some of the things like renal and some of the major sort of specialised operations. In terms of just how that spends per person within Northamptonshire, effectively, therefore, we spend over £1,000 per person on Northamptonshire. So it's just a different way of cutting that cake. And again, that gives you a flavour for how much goes on to across the various areas in terms of acute, primary care, mental health, etc. So moving into 15-16, we had a good allocation in 15-16. We're well below what they call our capitation target. So the government has a formula by which it decides how much money we should receive. We currently receive under that allocation. So at the moment, even after that allocation, we're still about 30 million distance from target in terms of where we are, in terms of what the government would expect us to receive, which is just under 5%. But that did mean we got some extra cash this year, which, given the financial issues, was most helpful. What we will have to do this year is, for the first time, is whereas last year we delivered a sort of break-even position, this year we will be required under NHS rules, as all of the CCGs are, to deliver a one-year surplus in year. We will get that back, so we're not losing the cash, but that does make it a little bit more challenging for us in this year. We've developed a plan to achieve our targets, but clearly, as a responsibility for the sort of health economy as a whole, we do recognise that providers are having some planned deficits. So over a medium term, we're coming up with a plan which will try to deliver a sustainable financial and service provision across the whole county, including all the providers as well. And the Healthier Northamptonshire programme's the sort of vehicle for that. And that will look at how we commission service and how the providers provide their services in terms of collaboration across themselves, and how we can change sort of patient pathways, etc. Just going into 15-16, therefore, we had an allocation uplift. Again, what we're showing there is where the allocation's going in terms of this year. As you can see at the bottom, we've had to increase our surplus, so we haven't actually been able to spend all that 54 million this year. But you can see again, as you predict from the previous chart, the bulk of the money has gone into the acute sector. And also we have what we call this year the Better Care Fund, which is where we work with the county council to commission services and integrate services together and look to how we can improve by working together across those areas. And we've also identified some funding for transformation, and again going down the list there. The other thing underpinning this, as ever in the NHS, is we have a challenging savings target, or what they call QIP, which is quality and improvement and productivity. So we've got quite a tough savings target to underpin some of those investments. and that's going to continue in future years as we roll forward. Because although the NHS has been promised this sort of £8 billion over the coming years, that's underpinned by another £20 billion of savings. So we've got to get into the mindset that there is some investment, but clearly we have to drive some cost and efficiencies through the system as well.
Hopefully this is working. Good. So thanks, James, Darren. And first of all, thank everybody for turning up tonight. Nice to see you all. And interesting, challenging now for the interpreters of putting the Welsh accent on the presentation. Good luck with that one. So, right then. See if I can make this work. Yeah. Right. As accountable officers, because although my title is accountable officer, what I'm going to go through is in a bit, it's a team effort. Everybody who works within the CCG is vital, and we work with our colleagues and partnerships, which is what I'm going to try and do and bring out in this presentation. So, we're led by management and clinical directors, and obviously our chair is a GP himself, so very much clinically led. What are, in essence, our statutory and responsibilities? If you looked at the guidance, they come under sort of 4 things. They come under sort of commissioning, finance, governance, what they call cooperation. But what it actually means is we've got to work in partnership. We've got to watch every penny we ever spend, and we've got to deliver services that have a good quality and are safe for the money we get. That's what we've got to do. So this is the team. We're going to go through the team. So Darren's been up and presenting, the chair. So, and then this is what we call the sort of management team, the non-GPs. So we got Helen, Chief Operating Officer. She makes sure we all have governance. She's sitting up here. You can ask them all questions, keeps us on track. We've got Janny, who will sort all our commissioning out and our primary care strategy, make sure we deliver what we need to do, and our strategy is online to deliver our statutory duties and gets what we need for our patients, the population we serve. I'm obviously the interim AO at the moment. Obviously, my substantive post is the Chief Finance Officer, but I've left that in James's capable hands at the moment. So hopefully he's keeping a good eye on the money while I'm not. We've got Peter, who's our Director of Nursing and Quality, and Catherine, Director of Contracting. So the management team. But in here, we've made a bit of a change in this last year that we've gone by. We have now got 5 clinical directors. The last one to be appointed is Naomi down the bottom. She's not with us tonight because she's on annual leave. But we've got plenty of work to do when she gets back. And then we've got Raf, as Tom again is not with us tonight, or Raf, and we've got Matthew here as well. And they'll come on to talk about what we've done and our achievements, but I'll just highlight a few of those things. But we are a clinical commissioning group. And these guys are the sort of help make sure we're heading in the right track and we understand what's going on in primary care, not just acute and everything else, and help us get there. Okay? So we've had some challenges in here. We have A&E, and we're still struggling to hit our A&E performance. All year we've struggled with it. We're getting there with NGH at the moment, Northampton General Hospital, but with Kettering we're still struggling, but we're working hard. GP practices, the on-day demand, what they are seeing on a day-to-day basis, we're struggling to make sure. We've got a challenge about recruiting as many GPs and primary care staff into the counties we've got. We are one of the most challenged counties in England to do that. So we've got to work hard. Community services, we're working hard with our community providers to get that to where it needs to. So you can support the acutes, support people, and people can have the services they want where they want them. So they don't always have to get to the acute hospital to be seen. So primary care can see them, community service can see them. RTT, the referral to a treat, so that's the time you see a GP and the time you get treated. We're struggling with that, especially in the north of our county at the moment. So we're dealing with that. Finances, we were, during the year, the 11th challenged health economy financially. We're probably not in that category at the moment because that's the hard work of people, but we were challenged. Engagement, we've had to work hard on the engagement. We're not there. We've still got some work to do to improve it, but we're making the efforts to do that. And as I said, we have to improve our clinical leadership, and we have appointed 5 clinical directors to improve that, to get us engaged. But that's not it. We've got a lot more to do. It'll keep going. So, as Jim said, we delivered the challenge. We hit our control total, but that's in the context of being the 11th challenged health economy. At the same time, and this is where partnership really comes into play, we did agree the Better Care Fund with the council. We signed it off last year. It wasn't easy. These relationships aren't easy, the partner organisations, but they shouldn't be. We need to be challenging each other all the way to get the best we can for the population we serve. If it's easy, we're probably not doing what we should do. And we have to challenge each other. And they are challenging meetings, believe me. Primary care. We have got to get that up to where we need it to be and get the GPs we need, the primary care services we need in the county so that we can deal with the patients so they don't turn up in A&E, they can be seen when they want to, they can have an appointment with the GP they want to. All that's got to happen. So we've had all these challenges in here, but at the same time, we've taken on what's known as co-commissioning. This is, we now influence the GP contracts with NHS England. NHS England currently still have the statutory duty for the GP contracts, but we influence it at this moment in time. We've signed up to do that. Not every CCG in the land has been allowed to do that. You have to put that in the context of being in the 11th challenged financial health economy. So you can see that NHS England are backing us to try and do and deliver stuff for the real changes for Northamptonshire. So that was a big thing for us. And we had the blessing of our GPs. That's what they wanted us to do, our member practices, and that's what we delivered. So well on our way. Going forward, we might go to full delegation where the CCG actually has control of those contracts as well. But obviously that introduces who knew conflict of interest and things we'll have to deal with. But Helen will keep us on track with the governance, so we're not worried. Okay, the challenge. Okay, you'll have seen in the press, they were talking initially about a 30 billion challenge for the NHS by 2020. The government have then said, during the election, promised 8 billion. So that's now gone back to 22 billion. So we now have a 22 billion. What we have done in Northamptonshire, with our local authority, Northamptonshire County Council, we've sized what our gap is over the next 5 years. So that's everybody sharing where the financial position is and where we're going to try and do and what the gap is. And basically, that's 279 million is the gap for Northamptonshire. That's for all the providers, all the commissioners, including social services of the council. So quite a challenge we've got. That's why we believe we have got to do this together in partnership with all our partner organisations, the council, the acute, the mental health, the community, primary care, ambulance trust. We've got to work with all of them or we will not achieve what we need to do for the population we serve, because that's what we're here to do. So, what next? We now need to take the Better Care Fund onto the next level, because this is where we will get some of our efficiencies, deliver integrated services to get positive results. The 5-year forward view is the challenge. Now, this is about modernising services, having services in a completely different way. And they're allowing us to try and say, support people to stay well. That's what the main thing. They want us to stay well. Big chunk of that, we'll need public health from the council to work with us. Prevention, healthy. We're working in partnership yet again. We've got to reshape the services. Have our 2 acute hospitals work closer together, work closer with the community trust, work closer with primary care. Co-commissioning, primary care services, we will have to change them. These are the challenges we've got for this year. At the same time, we are a membership organisation with our member practices. At the moment, we work at 8 localities, but we have 3 federations. They will develop, and we've got to ensure the long-term plans are there to deliver the services we need for this population. So, what is it? What are our plans? What I've tried to highlight in this is we are going to have to do this in partnership. The CCG is going to have to work with all its partners, primary care, the community, NHS England, the ambulance trust, the acutes, the voluntary sector. We're going to have to work with everybody, make sure, and we will have to engage with the public of the changes we're going to make, because it's not going to be easy. It's going to be challenging. And it won't always be good news that we come to talk to people about, but it will be challenging, and for the right reasons we need to make the changes so the services are the right care, right quality, the right time for the people of Northamptonshire. With a gap looming of 280 million basically going forward. But we can solve this. We believe we can solve this, but together. And that ends my presentation. And thank you all. And I'll hand over back to our chair. Thank you.
Thanks very much, Stuart. I know I didn't ask about the American accent. But if we can hand over now to one of our clinical executive directors, Dr. Az Ali.
Thanks, Darren. Thanks, Stuart. So I'm Dr. Az Ali. I'm a GP in Wellingborough, and I've been in my current post here at Nene for the last year. I think it's quite fair to say that the last year has been extremely challenging, hard work, interesting, but there have been a lot of positive points too. So, from a cardiovascular point of view, we've commenced the delivery of community cardiac rehab services at Daintree Hospital. This is following collaboration with the Daventry Heart Support Group and Health Watch, and also the NGH. The benefit of this is obviously that community cardiac rehab is... So is this working? Can you hear me okay? Sorry. Is one of the most impactful modalities when people have heart failure. So there'll be improved access for that community in that area, and also hopefully prevent acute admissions and readmissions. Moving on from there, we, with our cardiology lead, Dr. Javed, who was mentioned earlier on, I've done a lot of work with the GPs in the county to upskill them with respect to atrial fibrillation. Now, you may or may not be aware, but atrial fibrillation is quite a significant risk factor for people developing strokes. So this work that was done has actually shown to have month-on-month reduction in strokes, whereas previously we were actually going up month-on-month. So that's quite a positive. From a cancer perspective, prostate cancer patients were canvassed by Prostate UK, and it was the opinions and the help from these patients have actually influenced the redesign of some of the work that we're going to be doing going forward with respect to stable patients with prostate cancer being dealt with in the community, i.e. closer to home, which is obviously beneficial for those patients. The quote at the bottom there, I'll give you a second to read, but the context of that is that previously the Nene commissioning would only commission breast cancer reconstruction on patients who'd had breast cancer and only have an operation, and have the reconstruction surgery on the affected side. But actually we did quite a lot of work with the breast cancer group and also the local consultants, and it became very apparent that this was quite inequitable. And as such, the policy has been revised such that this cohort of patients are now able to have reconstruction surgery on the non-disease side. Main reason for this is because they were struggling with asymmetry. So it does show that as a CCG, when there's sort of clinical evidence, there's a patient engagement, that we do listen and we do take action. From a weight management perspective, we've had quite a few engagement events and worked together with our current providers, and we're now looking forward towards the back end of this year to develop a sort of an end-to-end weight management service, which was more tailored towards the well-being style type of intervention, such as exercise and diet, which has currently been slightly lacking, if we're being completely honest. And I think this will really benefit the patients in our county, bearing in mind that we are an outlier when it comes to obesity across the country. So the challenges, I think it's very clear from a cancer point of view, the earlier the diagnosis, the greater the potential for improving outcomes and survivorship. So what we're trying to do locally is work closely with our public health colleagues to identify areas of increased prevalence and support health promotion and augment health checks in those areas. In addition, leverage on the work that's been done by Public Health England, that's been done in the past, such as sort of kidney cancers and esophageal cancers, and to support sort of early diagnosis. And also work closely with our GPs, bearing in mind the updated NICE guidance on 2-week waits. From a weight management perspective, I think our biggest challenge will be to develop self-management support and to empower these patients to look after themselves, and that is the challenge for us. And obviously, there's going to be a financial challenge. You know, we've got an aging population, increasing demand, so we're working very closely with Public Health, NHS England, third sector, primary and secondary care to try and improve prevention, self-care, conservative treatment, and deliver care as close to home as possible, if appropriate, releasing secondary care to deliver the care that they need to. Okay, thank you.
Thanks a lot for that. I should have said at the beginning that we'll take questions at the end. So if you do have any questions as we go along, if you just note them and we'll cover them all off. So over to Matthew Davis, who's our lead for primary care, is also going to take over the integrated care closer to home discussions as well.
Thanks, Darren. I've now got a bit of a problem. I was going to walk, talk, read my notes and change the slides at the whole time. So there might be the odd break in my presentation. So if there is, just talk amongst yourselves while I recover. So I'm going to be trying to read my notes and my handwriting and the slides all together. Thank you. I want really just to talk a bit about the context of primary care in Northamptonshire and NEN CCG at the moment, because we know from the engagement, from some of the work that Healthwatch did, that we have, the context is that general practice and primary care is under a huge amount of pressure at the moment. We've got an ageing population, we've got a change in the demography, we've got one of the fastest growing populations in the country. I'm a GP in Daventry, and I know that up until the beginning of this year, there was very little of the planned building going on, but it's just gone mad. So patients are registering, we're struggling to recruit new GPs, people are struggling to get the appointments that are suitable for them, and that's putting pressure on everybody within the system. So to talk about where we are as a CCG, during the past year we've been collecting something that we call the Primary Care Development Scheme, and it's giving us a real-time sense of the amount of pressure that there is in general practice, the amount of appointments that practices can provide, but at the same time that people are needing those appointments, and people are quite rightly looking at how they are living their lives and wanting to have things done in a different way. They're wanting access in the evening, they're wanting access first thing in the morning. We know that over the past 5 years, there's been a national increase of 40 million consultations for general practice. And I would say this because I'm a GP, but at the same time, the proportion of NHS budget that is spent in general practice has fallen from just under 11% to 9%. So, you know, it's a context, and it really demonstrates that you are going to have difficulty recruiting people into that service, and Northamptonshire is changing. So context, I think, is really important. What I'm now going to do is talk a bit about what the CCG internally has done over the past year, and then a bit about some of the things that we're doing and working with GPs to try and help change that situation at the moment. So what's happened about our localities? We've got the colour-coded groups around here, where Darren talked earlier on about how we were changing the clinical input into NEN CCG. And what we've done is we've got the 5 clinical directors who are taking responsibility for different areas on a more strategic level. But now we've got 8 new clinical directors within the team who are beginning to form a locality chairs group that is allowing us to have that feedback into practices through another group of GPs. They very early on last year, when they were being appointed, looked at the priorities that they've got. And those really haven't changed since practice-based commissioning came along. But it's about how you work within your community and engage with patients, and but at the same time as you preserve that locality feel. So they're working together. They're just starting a development program with East Midlands Leadership Academy, which exposes them to some of the different challenges that Az was mentioning in his presentation earlier on. We've also developed internally. We've got a clinical director for primary care. Kamal Sood started that, and now Naomi Caldwell has taken on that role. We've appointed Julie Lemmy as a head of primary care, and that's been really important while we move into the different contracting round that we've got at the same time. Louise Tarpley has taken responsibility for developing the locality support managers, who have had some very specific things where they've become much more of a direct link from practices to the CCG. And then Janet's been supporting us over the past year and a bit, in her role of actually having that director leadership, which is really important as well. So, co-commissioning, we've talked about it. What does that actually mean? When CCGs were set up, quite rightly, there was the issue about GPs being influencing how their contract was managed. So the NHS England continued to look after most of what general practice was paid to do. But there was a realization that actually general practice is vital to the change that we need to make to helping to manage frail older people in the community and allowing them to have the best experience of care. So there's a sense that we now need to work together with NHS England and with CCGs to be able to develop plans to help general practice deliver different services. So we've got a co-commissioning body that is chaired by one of our non-executive directors, Paul Bevan, who work with NHS England and with our local providers of service to look at those contractual issues that are going to allow us to make much better decisions about building general practice as a way of looking after people in the community. I thought I'd just talk a bit of one of the initiatives that has come directly out of the co-commissioning subgroup is the co-commissioning group is the workforce and education subgroup. When the changes came about 2 years ago with the Health and Social Care Act, there was a fracturing of the relationships between the people who provided education, the people who provided workforce planning, and the people who actually did the work. But what we've been able to do is bring Health Education East Midlands, which is around education, around registrar training, the NHS England and the CCG together to actually develop a work plan as to how we can encourage people to come and train in Northamptonshire, and then once people are training in Northamptonshire, we can actually persuade them to stay because it is a great place to live and work. And there's a couple of things that we've done there that I'd just sort of mentioned. We've built with the deanery in the East Midlands what we're calling a foundation year, so that people who've come through their 3-year training programme actually get the ability to have some extra skills over supported over in a 4th year of training. One of the general hospitals, NGH, are keen to give people skills around care of the frail elderly, which is just a theme that runs through everything that we need to do. In the CCG, some people are going to be involved, want to be involved in doing the kind of things that we're doing as GPs, and we're offering them exposure to bits of work as far as those things are done. It's also really important that we know actually what is the situation. So Health Education East Midlands, along with the CCG, are doing a workforce analysis. Do we know what it's likely to look like in 5 years' time? We've also had some infrastructure bids, which were supported through the National Fund, so that we're supporting those. And then we've also had PMS, which is Primary Medical Services Review initiated. And this is a way of making sure that the money that is spent in general practice is spent in a fair fashion across all of general practice, because there's two funding models at the moment. And this is a process that's going to go on over probably the next 3 to 4 years, but will allow us to make sure that all practices are funded in a fair and equitable manner. I mentioned care of the frail elderly, and I think that our responsibility of clinicians in the CCG are one of those main priorities must be how we allow these people to live their lives. If we go back to our vision and our mission, and that we allow them to live their lives as well as possible. So what I wanted to do is pick up on some of the schemes that we've managed to put in place over the last year, and probably two of the ones I want to talk about particularly are the care home scheme. And this has been a way of identifying how do you support people who've moved into either residential or nursing care to be able to not have to ring EMAS or the care home to ring EMAS every time that there's a problem. So we've identified that if practices develop a relationship with a care home, they're much more likely to be able to rely on that practice to respond at an appropriate time. So we're looking at having regular ward rounds and medication reviews which allow us to include pharmacists. I've got one booked in. I look after one of the care homes in Daventry. In a couple of weeks' time, I've got a medication review booked in with a specialist care home pharmacist, which is great because we actually get some time to spend looking at that medication and deciding how do we optimize that. We can also then identify the different services that will be allowed to help that person. And actually, if them and their family wants to decide that actually I don't want to be admitted to hospital if I get a chest infection again, we can get that in place so that in the middle of the night when there's not people about who know them, they can then have the appropriate care. The other thing is the so-called collaborative care teams, which is looking at those people who are the most vulnerable and actually building with them at home a plan which allows them to say, I'm part of working out what the future of my care will be, but also including in that, how do we help them contact the appropriate voluntary agencies? How do we make sure that their carers have had the support that they need to do? And that's now up and running in the 8 localities, and there's different models that across the 8 localities. So what we're going to be able to do in 6 to 9 months' time is look at what is the most effective way of supporting those people. And just really a mention of what does that mean for the future in what are going to be the new models. So we've got 2 new provider organisations that have emerged over the past 18 months to 2 years, 360-degree care in the north of the county, GP Alliance within Northamptonshire. We've got 2 existing GP presiders with Lakeside Plus and PML in there, and then we've got the development of the super practice and their associated Vanguard bid as well. So those are all things that are going to develop over the course of the next year. And what we've come to realise is that if we can support that process through the development of what we're calling a quality contract for primary care, we'll then be able to concentrate on care of the frail elderly, access to general practice, and make sure that those are at the centre of all of our planning. Thank you. So that's, I'm now going to have a quick sip of water and take a deep breath and talk about joint commissioning. So you're quite, this is where I will have to turn my notes over a bit quicker, so there might be a little bit of shuffling and humming and hawing in this presentation. Joint commissioning, so what is it? I think, you know, when I talk about general practice, most people know what general practice is, but joint commissioning is one of those kind of jargon words that gets bandied about, and you know, you expect everybody to know what it is. Joint commissioning is when the CCG and the county council work together to deliver services, and this probably is one of the key things that we've got to get right over the next years to allow us to care for the frail elderly population, to allow us to have access to general practice, and to allow us to get those things like the RTT, which was talked about earlier, in place. So the theme just runs through it. So what I'm going to do today is talk from a health perspective, because this is NEN CCG, about probably our flagship bit of joint commissioning, which is Integrated Care Closer to Home, and the schemes that underlie that. Take us through some of the challenges, look at what's involved in the BCF, and then talk briefly towards the end about a very important but very successful response that we've come up as a joint commissioning body to the Winterbourne View review that was published. Integrated care, am I holding the microphone right, or can people hear? Okay. If you want to go to sleep, I have been talking for quite a long time, so don't worry. Integrated care closer to home. Again, buzzword, we talk about it the whole time. ICCTH, yeah, obviously. It's the principle of the right care being delivered by the right person at the right time in the right place. So we absolutely need acute hospitals. If you have a heart attack, you don't want me looking after you in Daventry. You want to be in the cath lab at Kettering General with somebody sorting you out. You want the EMAS guy there as soon as possible. But we need to describe the things that we can do to help people not be in hospital, because we know if you talk to anybody that there's a group of, and they tend to be the frail elderly people, they tend to be people with dementia who struggle to get out of hospital. And we have to question ourselves, if we had other services in place, would they have not got into hospital? So ICCTH, Integrated Care Close to Home, is our programme for managing and doing that. And in the past 12 months, we've begun to build a way of delivering that through the engagement with the providers of services, beginning to progress an integrated care model, and have the roles and responsibility of the Better Care Fund, which underpins all of this, described in a governance structure that seems to be working. But that leaves us with challenges around ICCTH. And the biggest challenge is that we have an urgent care system which we need to be able to do things for everybody experiencing a problem, a crisis. And that doesn't matter whether you're somebody in Brackley who is to describe the leafy suburbs of Northamptonshire, and you've got good support, but you're a long way from the hospital, so the response for that person will be different to somebody maybe who lives in the eastern suburbs of Northampton, who is much closer to the hospital, but doesn't have the same social support. So we've got to develop an urgent care solution that matches the scale and challenge, but I can't fall out with James and Stuart at the same time about the money, because we are constrained by what we have to do. So it's really important that the projects that we bring forward, and there's a big reporting sheet across a number of programs, actually is clear about what we are going to do, what our aims are going to be, and how we're going to do that. But also building contracts with our acute providers in 16-17, building relationships with the council that allow that to happen. This just gives you a flavour of what it actually means in 15-16. So if we look at the whole number of non-elective admissions, that's everybody who goes into hospital unexpectedly, we need to fulfil our objective of ICCTH to reduce that by about 40 a week. So actually, if you look at the 8 localities, that's 5 admissions a week, 1 a day. So we're not doing things that are impossible, but we've got to remember that's against an increasing population, a cohort of GPs who are under pressure, who are struggling to recruit people as well. So context is all. You might think that's easy. So we've talked about the collaborative care teams. We've talked about care homes. Another really something that's up and running now is Acute Liaison Psychiatry. A lot of people attend A&E who would be better served somewhere else. Some of those people have an acute mental health crisis. Some of those might have had problems with drug and alcohol, and other ones are the younger teenagers who have done something impulsive. And in the past, the only response to that has been a medical response, which has been check you're alive, check you haven't taken an overdose, which is likely to threaten your life. But beyond that, it's been very difficult to answer. The acute liaison psychiatry teams are making a much more sophisticated response to that. And actually, as a GP, on the other end of this, when in the past you'd see people come out and they'd say, well, I went to A&E, but all they did was take some blood off me and send me home, and you'd think, oh, what happens next? People are coming out with plans as to how they're going to be supported in the community, whether that's around drug or alcohol or mental health there. And that's been a big difference. So that's the front door, how you can help acute general hospitals. The other bit is looking at how do we help people get out of hospital, because we know that in Northamptonshire we have an issue around how we manage people in hospital. And as I said before, you've got those demented and frail elderly people in hospital for too long. So we're working with partners at NHFT, partners the Acute Trust and North NCC to get people home, to actually assess their capabilities at home rather than on a hospital ward, which is much more appropriate. This really gives you a flavour of the BCF and the extent of the ambition for the BCF. So there's quite a lot in there. I clearly have concentrated on some of them. I think the third one down is vitally important in that we actually build the carer support network for people, because we know that informal caring arrangements are absolutely vital to a lot of people. But that just gives you a flavour of the whole range of things that are needed to do to help achieve that reduction in non-elective admissions. What are the challenges? Well, I think we've articulated those. There's a financial challenge, which is both to the council and the CCG. We've got to have just this relentless focus not on building plans, which we've been very good at in the past, but actually delivering those plans. And we've got to have good relationships, because when it comes down to delivering change, you've got to trust each other. Next 12 months, lots to do in the joint commissioning agenda. So this is moving away from the narrow ICCTH agenda to the wider joint commissioning way of doing things. I've put up the top there, development of the Wellbeing Community Interest Company, which is going to be really important in managing both that first bit of people's experience of health and social care, so that we can help them develop a resilience within themselves, but also when people have touched health and social care, finding places for them to go. But again, a really wide ask that Stuart, I think, alluded to when he said there's a lot to do, and this is just one area of the activity that the CCG is involved in. I said I'd talk briefly about Winterbourne View, and I really feel that this has been a success of joint commissioning. The quality committee, the joint quality committee of Corby and Nene, have almost developed this as a pet project, but a very important thing. And it's really ensuring that some of the most vulnerable people in our community, so these are people with severe learning disorder, disabilities, and really difficult behaviour associated with that, actually have the best chance to live our mission statement and our values. And we identified that there's 5 people who are remaining in inappropriate hospital settings, either in or outside Northamptonshire. And by the end of December this year, 4 of them will either have been discharged into some places that are being built at the moment. So there's been a real focus on allowing the most vulnerable the best experience of care, and being part of the quality committee that's chaired by Christina Edwards, one of our NEDs, it's actually one of the things that when you see the progress over the months, you can feel most proud of, that actually we're generating individuals having a genuinely better experience of care. So that's all from me. You'll be pleased to hear, and I'll hand you back to challenge the interpreters with Darren's American.
Thank you, Matthew. That's so you covered quite a lot of ground. We just have one final presentation from Dr. Tom Evans, who is one of our other clinical executive directors, but unfortunately on holiday. So he very kindly did a video presentation. So again, another first for us. So hopefully this will work. Just click it on. Just click it. Okay.
reduce demand on our urgent care system has to be sustained. So the priority is to look for sustainable long-term solutions for our county from an urgent care point of view. And this can only be achieved with primary care and patients at the centre, with working collaboratively with all organisations that are involved in the urgent care system.
I would thank Tom if he was here. So this is our chance to start asking questions. But just before we get there, there's one bit around well-being, and unfortunately, Dr. David Smart, who was in the audience, who had to leave early, but often champions this next slide, and it's about having a great dream. So many of you may not have seen this, but it's about action for happiness. So we know that people who have greater well-being have happier lives and healthier lives. And this is if you type in great dream into, again, a search engine, this will come up. And it's about 10 key steps to happiness. And each of the words spells great dreams at the beginning of the word. So it's about giving, so do things for others, relating, so connect with people, getting out there. And so it's great that you've come out here tonight, because that's part of your well-being. You may not think of it like that, but it is. So exercising, so it's really important that you take care of your physical health. Appreciating, so just taking time to notice the world around you. Trying out, so being curious and just trying to do different things. After this, I'm going to a dance class, so it's something new for me. Dream, so have goals to look forward to try and aim for them. Resilience, so find ways to bounce back. So there's often challenges that we all experience, and part of it is just being strong enough to know what the right thing to do is and to go after it. But getting in touch with your emotions, so take a positive approach to things. Having acceptance, so being comfortable with who you are. So there's many things that we can't change about ourselves. I wish I had a full head of hair, but I can't. So I enjoy my baldness, and it's just one of those things that you have to pick and choose the things that you need to accept. And then meaning, so it's being part of something bigger. So when we're isolated and stay at home all day, it's just not a good thing. It's important to get out there. So again, it's something that we promote as a clinical commissioning group, and it's just something that I always try and finish our talks on, just for something positive for you to take away from tonight. So that's our last slide. It now gives us roughly till 7 o'clock to have questions and answers. So we have Irfan, who's going to be our roving mic expert. We've found by experience it's just easy if you want to put your hands up, and then we'll take it as they come. So thank you very much. If you could just say your name, just it helps, and then I'll direct it to the people who most appropriate.
I'm Wendy Steele. I've had concerns regarding mental health that I've addressed here at every meeting since Nene Commissioning was born, and I still have those concerns, particularly about mental health crisis services and secondary care services, mainly the crisis teams and the people being discharged from hospital. I was a bit confused with the last presentation on the video. The gentleman seemed to be talking about the acute services, urgent care services, and I'd like to have seen a little bit more of that attention being given similarly weighted to the mental health crisis services. I'm pleased to see that the A&E Liaison services have improved for mental health, but I have great concerns. Over the 3 years I've watched the crisis services, the mental health crisis services, deteriorate. I've experienced that myself, and I've witnessed it with the people around me, and I believe that's quite a large group of people that are quite vulnerable and not not necessarily in a position to speak up. And I fear that there is less attention given to mental health. And that frightens me. You know, I've seen it's not amongst the priority list. Doesn't seem to be given much weight money-wise over the next year's plan. Can you reassure me in any way?
Okay, thank you for that. Which is that you, Janet, or do you want Matthew? Okay.
I think the parity of esteem is really, really important, and it's something that we don't pay lip service to, and we are absolutely committed to it. The crisis intervention in mental health is monitored through the themed contract quality meetings between NHFT and NEN CCG. So what they do is they look at individual areas and assess the quality of the service that is being provided. The Acute Liaison Psychiatry service has made a difference to those people who are in crisis, who end up actually in the right service rather than the wrong service, because I think in the past those people did get poorly treated by the mental health services. We're absolutely certain that we'll monitor the activity of the crisis teams against what we've contractually done. We've got Dr. David Smart doing an independent review at the moment of some of those services, which is going to be completed by the end of September. So we've got an assurance that the quality is there. The other thing that we have done recently is developed something called the Primary Care Liaison Worker, because one of the difficulties that I'm sure you've experienced in the past and people have is that divide between primary care and secondary care, where as GPs will identify the need for somebody to have some specialist mental health services, but actually getting into specialist mental health services was very different. We now have attached to all practices some primary care liaison workers who are part of that community mental health team, and again signpost people into the right place. So parity of esteem is absolutely part of what we believe in.
Will the results of Dr. Smart's work be published through your website, through the membership?
Well, so they'll be part of the board of directors and governing body papers and the quality committee. So they'll be in the public domain. Yeah.
Yes, thank you. And I think, you know, we have been challenged certainly internally by our GPs to make sure that, as Matthew says, the parity of esteem. So the balance between physical and mental health is absolutely right. Yeah, there's a question. Do you want to wait for the mic?
I'm a chairperson at one of the patient relationship groups, and the practice that I'm at, the manager there was rather concerned that I had understood it, if I had done so correctly, that there was not only the drop of the 11% to 9% from NHS England, but the NEN Clinical Commissioning Group were also reducing amount of monies to the practices. But at one of the presentations, it said that you don't give monies to the GP practices. So I'm now a little confused that one explanation for a reduction in funding, where that reduction actually is, because it concerned us as patients.
So the question is around the potential reduction from NHS England, but then a query about whether NEN's funding of primary care. Yeah, so if I can hand you back to Matthew.
Yes, so I know exactly what you're talking about, Jane, because Jane's from Daventry as well. So there's two two elements to it, and the way general practice is funded is complicated, but there's a bit which is called our core funding from NHS England, and I mentioned this PMS review that is being started and has started this year. And what is happening is actually both the practices in Daventry are PMS practices, so from next April onwards we will be having a change in our contract which will reduce the funding. Now, Nene CCG then has the ability to reinvest that money into general practice. So the money that comes out of the PMS reviews doesn't go back to the Department of Health. It stays in Nene CCG practices. So I mentioned in my presentation about building a quality contract, and part of the way we will invest that money back into general practice will be through this quality contract. But at the same time, James mentioned some transformation monies. We're investing another 1.3 million in general practice in Northamptonshire, in Nene CCG during this year. So yes, there's the reduction from the PMS, but there is reinvestment at the same time.
Okay, thank you.
Thank you.
Hello, I'm Wendy and I'm chair of Northamptonshire Cruise Bereavement Care charity.
You're welcome.
We have 60 volunteers working in Northamptonshire. We have over the last 3 years had no end of contact with different people in Nene commissioning to see can we get some help. And we see somebody, we talk to them for a while and then they move on to somewhere else and it all goes flat again. And 85% of our referrals come from GPs. And we just don't seem to be able to talk or get somebody who is consistent within the organisation, within your organisation.
Right.
Okay. Thank you.
Who wants to? Janet? Or do you want? Yeah. Okay.
Yeah, well, thanks for raising that. Probably what we could do, maybe separately from the meeting, if you can leave your contact details with me, I'll make sure that, either I or one of the team will get in touch with you, and we'll make sure that we have some continuity and make sure that the issues are taken forward. Yeah, so maybe just after the meeting I'll catch you and get your details.
Thank you. Yeah, and sorry if you've had that experience, because I mean, I know I've personally referred many people on to the service, and I know how valuable it is, so, and you've helped many people through. So, and any other questions? Yes.
Sorry, another one.
Yeah.
Going back to mental health, I guess. Is there any pressure that the Nene Clinical Commissioning can actually put on to the Foundation Trust Northamptonshire, because there's clearly issues with beds very often, and I understand that there are going to be difficulties, but patients are having to be sent out of area and sometimes to quite inadequate alternative facilities, which not only is there the travel, there's the lack of good communication where people in crisis are then not getting high standard of care, and the nature of the places that people are being sent to may well also be inadequate. I've had cause to contact the CQC with regards to a couple of people that have been in touch with me recently. And I just wondered whether you were in a position to put additional pressure when you do contracts and things.
Okay. Yeah. I'll hand you to Janet.
Okay, well, again, thanks for raising that. We commission most of our mental health services from the NHFT, the Foundation Trust. We spend round about just over £100 million a year with that Foundation Trust. So within that, a significant proportion will be on mental health. And as you say, there are some services that they don't provide locally, so people are sent out of county. I would say as commissioners, it's always really helpful just to get feedback, whether it's good, bad or indifferent. We do meet with our trust providers on a very regular basis, and again, perhaps separately from the annual general meeting, we'd just be interested to get any further feedback that you have, and we'll make sure that we feed that into the strategic contract reviews that we have. So we have a contract team and a planning team that meet with colleagues from NHFT on a very regular basis. And probably what we need to do is just get those things fed in. But the chances are that the issues you raise are already being discussed at meetings like this. But it's always good just to get that further feedback, and we very much welcome that. So again, if I can maybe get contact details later, we'll again just follow that through.
Thank you. Any other questions anybody would like to raise? No? Yes, go ahead. Irfan's running around.
Hi,
Yeah.
It's Tony Griffiths. I was just interested in part of Matthew's presentation when he talked about the joint commissioning, and I think one of his top lines was I think it was called a community interest company with NCC. I just wondered if you could explain what that is and what benefits you think that will bring.
Okay.
So sometimes you hope that people won't ask a question. I have to admit that the original slide for joint commissioning had Dr. Raf Poji on it, who's had to go, who couldn't come tonight. So my understanding, and this is, I have to admit this is an understanding, is that the community interest company is a way of looking at how services can be delivered more effectively in the community. Because at the moment there's a gap between what we as a CCG commission for tier 1 and 2. So hold that for a minute. I'll shout. So for mental health, for well-being, you look at a pyramid of care, and you have tier 1, which is essentially people who are struggling at home on their own, and tier 2, which is just primary medical services. And what we're looking at is tier 1 and 2 being delivered more effectively, because they're actually all over the place at the moment. So lots of different people are doing different things, and this is bringing everybody under one umbrella, so that people don't fall between gaps. Now, it's trying to take it beyond, and I'm using mental health as an example, to all of the different wellbeing services. And that great dream slide is a good way of looking at it, because exercise is really important. Meeting people is really important. So it'll be voluntary services as well. And so using that as a vehicle to do it more effectively.
Okay. Wendy again.
Yes, I'm sorry. It's me again. About personal budgets, personal health budgets, specifically for mental health. You talked about rolling them out, and I would like to say whoever's leading on that, presumably you have somebody who's in control of that. I suppose, to try and cut a long story short, I have some reservations about that system, having had personal experience of it. I think there's a potential there that money is being wasted in the attempt to roll it out too quickly. I mean, I don't want to go into my personal story, but if whoever's in control of it would like to speak to me, I could give some constructive information about how it's not very efficiently working at the moment. I think, too many people involved in the chain, specifically for mental health, which is resulting in a lot of a person's budget being spent on the administration of it, and not necessarily to the benefit of the person receiving the budget at the end. And I'm sort of 6 months down the line with this process, and it hasn't improved. I've given feedback on it, and it hasn't improved. And I can see a lot of money being wasted in that process. So please, could I connect with somebody about that to give some useful feedback?
Sure.
Before you roll it out too far.
Sure.
Because I don't think it's very effective at the moment.
Okay. We were chosen as one of the national pilot
Yes,
sites.
I know. I was worried about that pilot.
And part of it is to get feedback from, so that we can, learn how to strengthen the processes.
Yeah,
so
my feedback has fallen on deaf ears at the moment.
Okay.
So,
but we've got your details, so we'll be in touch. Yeah. Okay. But thank you for that feedback. It's important that we do make sure that it's as good as it possibly can be. Okay. Yes. Yeah.
Is that on? Yeah.
Yes.
My name's Joanna Steer. I'm the CEO at Deaf Connect. I'm very aware that the community that I represent is the profoundly deaf community who need the interpreters is quite small in the county, but there's an awful lot of people, 1 in 6, who have got some sort of hearing impairment. And I'm wondering how much impact the Sick of It report has had on the strategic planning for services for deaf and hard of hearing people in the county.
Ooh, I'll hand you over to Janet, who's or do you want? Yeah. Okay.
So what we're about to do in the next few weeks is put together our commissioning intentions for the next financial year. It's a process that we start usually during the summer, resulting in a first draft round about early autumn. So what we're doing at the moment is trying to make sure that we get as many inputs as possible by talking to groups perhaps like yours and other voluntary groups, and also talking to members of the general public so that we can generate our thinking for next year. Quite a lot of the commissioning intentions will be centred on services that we already commission, but where we feel that there are gaps in the service or services that are in need of review or refreshment in some way, then we'd always be willing to look at that. So again, if there is any feedback that you would like to give us, if you have a view from your organisation about where there may be gaps or where we could do better, it'd be really good to get that input. I can't promise at this stage that we're able to, top up all of the budgets for all of the areas. In the earlier finance presentation, we heard that the overall finance that we receive breaks out into £1,000 more or less for every person that lives in the county. Our job as commissioners is to make that go as far as possible. But certainly at this stage, we'd be very glad to have any ideas or any thoughts that you have. So again, we'll make sure that we make contact with you separately and have a chat to you about that. Okay.
Thank you. Okay, I'm sensing the energy levels are running low. And it's been a long day for many of us. So unless there's any other burning questions, I'd just like to, thank the team for their hard work over the last 12 months across all our providers, but, across our internal team. It's been challenging. There's a lot of challenges ahead. There's many of our partners here, and I think, as Stuart alluded to, we do have very strong discussions around some of the areas, because sometimes we need to work through those difficult and wicked issues to get to a better place that we deliver jointly better healthcare for our patients. So, and lastly, I'd just like to thank all of you for coming tonight and taking the time to help us shape our future delivery. So thank you very much.